Thank you very much, and good afternoon, everyone, and welcome to our July WebEx as part of our ongoing annual WebEx, yearly kind of monthly WebEx series looking at reducing medicine's harm across transitions. And it's an absolute pleasure today that we're introducing a kind of large team from Forth Valley who are here to share what their learning and experience has been around the particular topic of reducing medicine's harm across transitions. So before we do kick off in terms of hearing from Forth Valley, I just want to remind everybody that we're here to really learn from each other. We've established this monthly WebEx series to hear from each board, a different board every month, around their successes and also their challenges in the work that we've been supporting through the Scottish Patient Safety Programme, focusing on medicines, particularly in relation to reducing medicine's harms across transitions. So without further ado, some of the etiquette for today's WebEx. We do ask that you use the chat box as your main form of communication today. As our host has indicated, all of the phone lines are purposely on mute, and that's to reduce any of the background noise that we've experienced in past WebExes to really allow us to concentrate and hear quite clearly the boards that are presenting and sharing their work. So in the first instance, can I just ask everybody to introduce themselves in the chat box? Let us know who you are and where you are at the moment, enjoying the sunshine. We've seen already that Alec in Fife is obviously in a sunny part of the world at the moment. But also, if you're joining us as part of a group and there's more than one of you in the room with you, please also just drop us a line and let us know where you are and who you are. As I said, all the lines are on mute, so our main form of communication with you today is via the chat box. And we want to encourage everybody to use the chat box to ask questions, make comments, or share any kind of local wisdoms or reflections in terms of what Forth Valley share with us today. So we'll be monitoring the chat box, and we do have time dedicated at the end of the WebEx today to go through those questions. So again, please, we do encourage you to use the chat box. And hello, Carol and Fiona from sunny Aberdeen. It's great to know that people are in the sunshine, and we've actually got summer's days in Scotland. I won't mention anything to do with Australian summers while we're on this WebEx. So as I said, we do want you to use the chat box, and for those who aren't familiar with the WebEx functionality, on the right-hand side of the screen at the top, there is a blue chat box that we've highlighted here. If you click that, you should then be able to see the chat box functionality at the bottom right-hand column. Now, we do have here, please select everyone from the drop-down menu. However, this is actually all participants. So from the drop-down menu, in order to ask questions or make comments, please again make sure you pick and select all participants so everyone on the call can see your questions or comments. So for those that are joining the WebEx series for the first time, this is not the first one we've run. This is actually our 5th one for 2016. And last month we heard from Grampian, previously Fife and Esher and Aaron. And one of the things we're really keen to do is to pick out some of the key learning points from each of the WebExes as we progress. And hello, Louise. Welcome from Shetland. It's great for you to be able to join. And Simon. It's fair to say that at a national level, one of the key kind of things we've picked up is that medicine's reconciliation as part of reducing medicine's harm across transitions is a complex clinical process. And some of the levers that boards have identified quite early on for success is that senior medical engagement. And I think that we need to expand that now to really reflect the fact that it's senior engagement at all levels in terms of disciplines that really are the keys to success. And I guess we're really keen to support the interest that boards have of trying to capture feedback across points of transition regarding the quality of information that's being communicated. But equally, I think we're really keen from a national level to support the ongoing and learning and sharing and the different approaches that boards have taken to do with medicine's reconciliation. For those who weren't on the call last month from Grampian, the recording and the slide set are freely available on the SPSP Medicine's webpage. And the 3 key points that Grampian asked to share as some of the kind of reflections for the hour that they spent with us last month, they're really keen to share with anyone that's interested in more detail how they've developed the structured ward rounds and the use of admissions booklet to help actually increase the compliance of medicine's reconciliation. And they're being quite honest, the fact that they're at different stages in terms of improvement across the whole system. And I think that's a fair reflection in terms of SPSP and even its own natural evolution of starting in acute hospitals and over the last couple of years been spreading quite significantly into almost all areas of healthcare. So it's no surprise that there's a variation in terms of the stages of improvement across the whole system. And they've asked quite specifically, they're keen to hear from boards who are using electronic records. And again, not to preempt anything today, but we know that there are a number of boards that are using HEPA and using electronic records as part of their testing and improvement around medicines reconciliation. So perhaps there is some learning today from Forth Valley in terms of their presentation. So without further ado, I'm really keen and quite excited to be able to introduce to you the team from Forth Valley. So Monica, I'm going to pass you the ball, and once you've got the ball, it would be great if you could introduce everybody that's with you in the room. I know you've got a team of 6, and we're quite excited to have you all here today to share your experience. So Monica, that should be you with the ball just now. Monica, can I just confirm that you're still with us?
Hi, can you hear us?
Yes, we can indeed. Thank goodness.
Don't panic. So, hi, I'm Monica Ingalls, Programme Manager for SPSP for Forth Valley, and I'll just let the rest of the team introduce themselves.
Hi, I'm Scott Hill, I'm the Acute Lead Pharmacist here in Forth Valley Royal Hospital.
I'm Ross Cheap, I'm Senior Charge Nurse in Mental Health Admissions here in Forth Valley Royal.
Leslie Simpson, part of the Quality Improvement team in Forth Valley.
Carol Smith, Community Pharmacist.
Okay, that's us.
Okay, so I'm going to start off. So it's this is Scott Hill, I'm the Acute Lead Pharmacist here, and what I intend to do is just give some sort of oversight of what we've done with medicines reconciliation within the acute hospital. So I'll work through the process that we currently go through. I also want to show what we're measuring, how we're going about our measurements, then a few slides on our performance to date, and then some information about our successes and our learning and what challenges we're still facing so far. So really around about our medicines reconciliation process, we obviously work in slightly two different ways. So in our admissions point, the first person that sees the first prescriber that sees the patient will go through the normal documentation and try and create an accurate drug history from 2 sources. They'll document those allergies, the plan for the medicine moving forward, and then ensure that that plan is then transcribed onto a Cardex moving onwards. What we try and do is verify that by a pharmacist moving onwards, so that there's an opportunity for that to be verified before that then transfers downwards into the downstream wards. At a weekend, we try and supplement that. We will put a pharmacist in, but we try and keep to the same process, and we'll put a pharmacist in at certain times over the weekend to try and facilitate some of that and try and facilitate some of the discharge process as well. At discharge, again, obviously, the person completing the medicines discharge is responsible for making sure that those medicines are obviously reconciled at that point in time. Any of the changes to medicines are clearly documented, and those allergies again are documented, and if there's any changes during the hospital stay, that's recorded moving through, and that the IDL is then communicated and generated out from there. So how do we measure that performance? So what we do at our admissions for our admissions wards information is that obviously working on the information from the CEL, we'll randomly select 20 sets of notes and look at those retrospectively, so they're taken away from and looked at out of the sort of ward environment itself, and they're measured at that point to make sure that all the processes that are laid out within the CEL are captured, and then we obviously score that. For our admission and orthopaedic wards, it's fairly similar, but we just generate the 20 sets of notes within the ward on a monthly basis, and we run through the same measures. For discharge and the discharge measurement, it's the same notes that are used for the admissions documentation from our admissions ward, and they are then used because as it's retrospective, we can look at the admissions part and then the discharge part as we run through the process. So this next few slides just lets us look at how we're performing as such. So first of all, it looks at our percentage of patients with MedRec across the 24 hours. and that's across all the 5 measures within the CEL. And what you can see is that from March we were, what you could say was performing fairly poorly, and over time, as we've increased our engagement, and we can look at some of our successes, and we'll talk about them a bit later, you can see that we've improved our position, and now we're tending round about the 85–90% mark on a not too irregular basis. Our next document, or our next slide, I say, is really about the inpatient prescription chart, and that's slightly better, and we can obviously see the starting mark was just slightly above the 50%, and we've gradually increased that, and we still, although there's variability in it, it's now sitting around about the 90% mark moving forward. Within our orthopaedic ward, similar sort of data, but we didn't start measuring that until about April of last year. And again, you can see slowly increasing, and hopefully we've done a little bit more engagement work at the tail end of last year, and that's driven the figure up slightly across those same measures as we use in admissions. And again, the appropriate Cardex at that point in time, slightly better at the start, and that's probably due to being in the orthopaedic ward area. And that's kept, obviously, some decreases, and what we can do is actually, because we have the information for both admissions and the orthopaedic ward, it gives us an opportunity to compare and contrast and have a comparison between them. And the next slide actually shows that dip in sort of February time of this year was similarly replicated within the admission unit as well. Thoughts are that might be around about new doctors and the change in how they move around in rotation, and similarly, if you look at just slightly beyond August when the new doctors come in, there's a dip in performance there from the admissions unit at that point. So for a discharge, we obviously measure the 3 measures that are there, and this is them combined. Better performance than what it is for the med-rec at the front door as such, and what tends to drop that performance is around about our allergy reporting and how we actually manage to bring the allergy data right through and into this. And at the end, then obviously transcribing that information into the IDL. We do that fairly regularly, or fairly well regularly, and that's because of our e-ward system, and that allows us to pull the medicines information and track any changes directly through and then put onto the electronic discharge letter as we move out. So what's really been our successes and our learning so far from our sort of process, and that's some of our success is certainly around about that movement around about our appropriate Cardex on admission, and that has really grown as we progress through our work around about medicines and medicines reconciliation. Our engagement, certainly of our acute care consultants, has led a lot of that development, and they've championed this as such, and we have our champions here who engages with certainly more junior medics, and we'll take the chance to speak to them and have conversations with them if we know that performance is slipping in that way. But also the way that we regularly use the information that we record and actually make people aware of that at the same point in time. So that's lifted into the monthly acute care and quality meetings. We use them on a weekly basis, or they can be used weekly basis in admission units, but also we take them onto areas like things like our acute drug and therapeutics, so that we at that level are aware of what work is going on and how well it's progressing. Our discharge information again is a fairly good measure and a success story for us, and now last 3 months we've have sat at 100% of an accurate IDL at discharge, which is a good place to be, and hopefully we can continue it moving forward. Within our orthopaedic wards, it's been mainly about a performance of Cardex on admission, and that's been increasing, and it's shown some growth and shown some success at that. And that, as I said, at the tail end of last year, we engaged in a stronger way around about our associate medical director and surgeons, and generated a consultant champion within that area as well. So really, our points for learning is really the consultant engagement part is really quite key and critical, and shouldn't be underestimated what value that brings to this process. I think with that engagement there, and that person or those people then championing that really is a good way to drive that forward, and that seems to be the most successful way of driving this forward. other thing is the sharing and visibility of those results at that point in time. They need to be shared so that there's an awareness across the board, and that's at that ward level, but also all the way through to your clinical governance groups and structures there, so that people continue to see and continue to be appraised of how MedRec is going. Our challenges, probably the same sort of challenges other people are suffering, is maintaining any momentum and change and round about this, especially with the competing priorities with VTE and sepsis at the front door. There's several competing priorities that need to be addressed, and it's maintaining that focus on MedRec at that point. Also, as I've spoken to before, it's round about the changes in medical staff and how that seems to impact on our results, and how do we manage to keep that and move that forward. What we are doing is we're in the process of moving across to HEPMA, so we're starting to experience some of the impacts of that and what that will mean for MedRec. We haven't had any measurements since we've gone live with MedRec, so obviously we do them retrospectively, so I think we'll get them in the next month or so. But we're expecting probably a slight downturn in some of our performance, but we should see an increase in some of our other areas of performance around about allergies because of the prompts the system uses to ensure that allergy data is recorded across the patient stay. And there's other ways that obviously HEPMA will continue to benefit, and we're looking at obviously using missed doses and that information, also ways to interpret where high-risk medicines are used in a real sort of time, so we can actually start to generate those reports and ensure that the patients are coming to no harm with the use of those sort of medicines. So lots of challenges, lots of hopefully success that we've been able to show with how we've been getting on, certainly within the acute ward, and I'll hand it across to Ross now.
Hello everybody, my name is Ross Cheap. I'm a Senior Charge Nurse in Ward 2 in the Mental Health Unit at Forth Valley, and I'll take you through basically our journey along the Medicines Reconciliation Road in the Mental Health Unit in Forth Valley. So, we first started looking at Medicines Reconciliation as part of the Scottish Patient Safety Programme in 2012. Now, that's not to say that we only discovered Medicines Reconciliation then, and in fact there had been work done in the years leading up to that. But under the auspices of the programme, we've started to look at it more thoroughly and use quality improvement methodologies in 2012. So on the screen just now are the main areas that we looked at in terms of what we were auditing for compliance on at the point of admission into the mental health unit. So we admit, like every place else, 24 hours a day, 7 days a week, and it was the 7 days a week bit that really gave us the biggest headache to begin with. You'll notice here that unlike what's asked for in the CEL, this doesn't include the allergies auditing, and we did that as a separate audit project, so it's not reflected in the first set of slides, but I'll come on to that later on. The big problem we had, as I say, with the 7-day work-in was that we moved our audit goalposts in many respects to look at what we'd completed 24 hours into admission. And because of the way that mental health services in particular were set up at that time in NHS Forth Valley, we really struggled to get over that hurdle, and hopefully you'll be able to see that as we move through the slides. The big problem that we had was when we initially started this process, we said that medicines reconciliation was everybody's job and it was part of the role of the team to undertake it, which in practice translated as it being nobody's job because we weren't able to say who was to do it at what point and when. So we had to kind of go back to the drawing board initially and make some changes to how we introduced the process and make sure there were some forcing mechanisms. So this rather crude slide is an example of how we encouraged our doctors to take part in the medicines reconciliation process. And we did that really by making it clear that they shouldn't be writing any prescription or putting pen to paper at all unless they had made certain of what medicines the patient should be on and whether or not the patient had been taking those medicines. As we know, things like lithium and other psychotropic medicines, to restart them at a prescribed dose when the patient's not been taking them can be particularly dangerous. We began by looking simply at, do we have the tools in place? So is there a medicines reconciliation form in everybody's notes in order that the medicines reconciliation process can be undertaken? And reassuringly that was present. I have to say my slides are less impressive because I'm not particularly good with run charts, so you have to forgive me for that. We came up with various different ways to improve our processes, and we did focus very much on process measures because our outcome measures didn't give us much meat on the bones, which in many ways was a good thing. None of our interventions, which I've rather grandiosely called bundles, had anything particularly scientific about them. There was nothing particularly high cost, and there was nothing high tech at all. So we started really by just looking at education and breaking that down per discipline. So rather than trying to tackle everyone at once, we broke off nurses and the nursing role in completing medicines reconciliation, and also got our medical staff together at medical teaching to underline and illustrate through case studies the importance of medicines reconciliation for the mental health patient's journey. We had to then engage staff and make sure that the staff were signed up to this being part of the role now, because whilst there had always been an awareness of it, there was less of an acceptance that this was a mandatory aspect of everyone's job. And engaging managers proved to be absolutely essential, and that was from ward senior charge nurses, deputy charge nurses, nurse managers, also into medical managers, to make sure that there was a consistent message coming through the organisation that medicines reconciliation was an expectation and something that was, as I say, mandatory for all clinical staff. Our second bundle was to review our paperwork and the layout of that, to make sure that there wasn't a mixed message that medicines reconciliation was an afterthought and sort of slotted in at the end, and to make sure that it was placed in a way that encouraged its completion early on in the admission process, rather than as the last thing you do before the admission is, so to speak, complete. We made sure that there were prompts around the wards, and in particular, we at that time were still on paper cardexes, which were in various different folders, and ensured that there was plastic prompts in them to encourage people to complete them. We did discipline-specific direction, so by that I mean that we broke down the checklists for admission into different disciplines and made it clear that the nurse couldn't say that the admission had been completed until the medicines reconciliation form had been done. Did the same for medicine, and obviously pharmacy had their own checklist in that as well. The first slide that's up there shows their completion within 24 hours, and that gradually increased over time. One of the main reasons to begin with why it wasn't completed over 24 hours was simply that there weren't any pharmacists there, and I suppose that helped to illustrate that we never considered it to be part of the nursing or the medical role to begin with. Using more than one source of information proved to be a nut we really struggled to crack in the mental health unit. It was considered that we didn't count the patient as one of the people who was a source of information, when in fact this is probably one of our most reliable sources in terms of telling us what they hadn't been taking. The change to measuring that at 24 hours again reflects that we weren't able to get more than one source often out of hours. We don't have access to emergency care summaries, GP practices are closed, and that limited the mental health nurses in terms of what information they could access. These are other slides that I won't go into any huge depth. Our plan for medicines improved, however, and that we think, and we can't really pin it down why we managed to get to that, was just it's a team working with our medical staff to make sure that there was some sort of discussion, even if it was a nurse who wasn't a non-medical prescriber completing the medicines reconciliation form, there was an opportunity to discuss what was happening with those medicines. And the sort of balancing measure on that and the effect that maybe we didn't intend was that nurses were better informed about the plan for the patient's admission. Rather than focusing on your own specific discipline's involvement and what needed to be done, you had a broader awareness of what the plan was in relation to the medicines that we were either stopping, starting, withholding and whatever. And as time went on and as we improved on our partnership working with our medical colleagues, we saw that documentation of a plan for each medicine improved. The check-in by a pharmacist, again, was something that suffered just purely by the 24-hour margin being there, and we don't have pharmacists and we don't have technicians out with Monday to Friday working hours in the mental health unit. We didn't manage to show any huge reduction in our incorrect or incomplete prescribing, and we never had anything that was hugely devastating to give us a good key example of where, if medicines reconciliation isn't done, something goes wrong. And although that's a good thing, it meant that we lacked the data to really illustrate the impact of what we'd achieved. So things that we learned were that we really got a true shining example of the importance of multidisciplinary team working, and ensuring that there was a multidisciplinary approach in terms of medicines management. There were many barriers to 100% medicines reconciliation processes, and this allowed us to kind of tailor local interventions, which again weren't really high-tech. They were more about review the paperwork, review the processes, and ensuring that there was the very high-tech notion of a conversation between the admitting clinicians to ensure that we were getting 100% compliance. Ultimately, we learned that we were able to affect change with little or no cost, and we did that purely by sharing knowledge amongst an already existing team. As a consequence of that and the ongoing work that we did around about medicine safety, and we did, as we moved on to missed dose audits, allergies, all the other things that go with that, we returned to medicines reconciliation periodically to make sure that we still had our finger on the pulse for that. But we're now at a position where it seems to be an embedded practice, and it's kind of devolved, if you like, down to the senior charge nurses in each of the ward to make sure that that is ongoing, and that's something that we check up on at our senior staff meetings to make sure that the senior charge nurses are confident in between our quarterly audits that medicines reconciliation forms a big part of the admission process to make sure that we've got safe prescriptions on the wards. You'll see for the data on the screen there that the plan took a hit, as did the allergy status, in the first quarter of 2016, and that was during a time where we were introducing the HEPMA system, and we were one of the pilot areas for the adoption of the JAC electronic prescribing system. So that is our sort of rationale for things getting a bit poorer in terms of our process around about that time. And as Scott's already said, there are forcing mechanisms built within the HEPMA system that ensure that allergy status is recorded, but there are other pieces of work to go on around about that in terms of medicines reconciliation.
We'll now move on. I'm Carol Smith. I'm a community pharmacist working within Forth Valley. So there was some development work carried out within the IT systems that allowed discharge information to be sent to the community pharmacies that were nominated by a particular patient when they were staying in the hospital. This work was to evaluate whether this information was useful, whether it minimized harm to the patient. So the process that we set up involved using the pharmacy care record, which is a secure record held at every community pharmacy, to send the IDL information, basically just the drugs, to the pharmacy. This report would then be reviewed and compared with any medicines that have previously been dispensed to that patient. We would check to see if there was anything awaiting collection where maybe a patient had ordered a prescription, then been admitted to hospital, and the prescription was still waiting for collection. When we received the first prescription for that patient, we would again check it against this report to identify if there were any changes, any discrepancies. These would then be investigated. We then aimed to discuss all changes with the patient or an appropriate carer to check understanding and to answer any queries that they may have. We came up with a care bundle. Over the period of 6 to 8 months that this project was running, the care bundle did have to be modified, but this was the final care bundle that we came up with, and the time frame that we looked at was that these records should be reviewed within 2 working days of receipt, and all these items should be checked, and then if the prescription was received within 4 weeks of the discharge, that was when we could use the discharge information quite confidently to compare with the prescription. This is a composite of all the results that we had. As you can see, the total number of patients that we reviewed records for, which is the bar at the bottom, that increased especially in the second half of the project. And whilst there was some variation in the results that we obtained, we were consistently good at the areas that the pharmacy are traditionally good at. So making sure that the prescriptions that were on the shelf were appropriate for the patient, making sure that any items that were dispensed were appropriate and that any discrepancies were identified. So the overall successes of the project showed that we met about 60% median overall bundle data compliance. for an area of the profession that had not been involved with any quality improvement work before. This showed very good engagement of the community pharmacists with the whole process. We were good at, as I said, removing any discontinued items, and the other part of the project that we showed a success with was engaging the GPs in a better communication pathway. Each community pharmacist involved with the project was asked to approach the GPs and establish a pathway, a method of how they wanted communications to take place. Phone calls, emails, what time of day, these were all established, and this has been beneficial not only for the patients involved in this project, but for all patients involved with the community pharmacy. We did have a number of challenges. Because the report was on the pharmacy care record, this is accessed by a password. If the regular pharmacist wasn't working and it was a locum, sometimes they were not aware of the project or didn't come with their password with them on the day. This was improved by making sure that the pharmacists who were going to be passing over to a locum spoke to the locum beforehand and reminded them to bring the password with them. This was probably one of the reasons why some of the records weren't reviewed within the 2 working days. The other major issue that we had was that patients don't all pick up their own prescriptions. They send in friends, neighbours, family. Sometimes it's not appropriate to discuss with the person that collects the prescription what's in there. So different pharmacies have come up with different ways, whether it's phone calls or written messages, to try and engage with the patients to make sure their understanding was appropriate. As an ongoing from this, with the introduction of HEPMA, which has already been discussed, obviously we will need to ensure that the information continues to come through. We've shown that we can reduce harm. We've identified certain cases where we have prevented inappropriate medications being dispensed. So we don't want to lose the benefits that we've gained so far. The challenges are hurdles to be overcome, not brick walls to block our way. Okay, I'll pass you over to Leslie. There we go.
For this final set of slides, I'm going to talk about the medicines reconciliation work that's been undertaken in general practice. Now, this was done as part of the patient safety programme in primary care, and it was delivered in Forth Valley through a local enhanced service. Basically, we had a protected learning session initially with all the practice staff involved to introduce them to the background, the rationale, the bundle measures and the data collection tools, and that also provided an opportunity for the practice teams to discuss where things could go wrong and where they could improve or make improvements in medicines reconciliation within the practice. The slides that you can see just now are the local bundle measures, and people who might be aware of the national bundle measures will see that they have been adapted slightly in Forth Valley, where for example, the second measure has the medicine reconciliation occurred within 7 days of the IDD being received, whereas nationally they use 2 days. This is a template that was devised for the medicines reconciliation process. So this is a template that's part of the GP system, the EMIS system. And certainly the feedback from practices indicated that the template was useful in terms of undertaking the medicines reconciliation process and helped them to follow changes over time. So this is the compliance with the bundle measures. So this data is from July 14 through to March 15, and the red line you can see is the overall bundle compliance. So basically practices selected 10 patients a month, and the criteria for them to look at was any patients discharged from a medical admission or any patients over 75 years of age who had been discharged from any inpatient stay. So you can see the overall bundle compliance rising from initially 76.5% when the work started, and rising to 93% by the time the piece of work came to an end. And you can see that there's an improved compliance across the various bundle measures. As part of the work, practices were also required to complete a reflection template, and this was done halfway through the data collection to reflect on the data, to reflect on the improvements implemented and any of the challenges. And certainly what the work has helped do is to identify within practices that there was variability in terms of how, when and if medicines changes were communicated to patients, and it also challenged the assumptions with GPs and general practice that medicines changes were understood on discharge and patients felt sufficiently informed. What the work has helped do is standardise some of that variation so that GPs are now reviewing IDLs on a daily basis. Practices have said that they're using the EMIS template and find that useful, and in some cases standard operating procedures have been implemented in practices as well. The practices indicate that patients are being contacted more reliably to discuss changes, and there was also the practices who told us they're making more contact with community pharmacies, and with a couple of practices actually setting up regular meetings with the community pharmacies to discuss prescribing issues. This slide just highlights some of the issues that came through. Most of them probably relate to the information, as you would expect, that's contained in the immediate discharge letter. I mean, despite some of these issues that are highlighted here, it should be emphasised that the practices do recognise that the IDL is a useful mechanism to collect, to share information. But some of the issues were that the IDLs were not sent quickly enough from the hospital, and that was particularly an issue from some of the community hospitals. The medication list was not always accurate, and the reasons for stopping drugs wasn't always clear. So sometimes a drug would be missing from the IDL, and it wasn't clear if that had been stopped or if they'd just forgotten to include it. Sometimes IDLs were being generated, but then the patient's discharge was delayed, so the GP would go off, try to track down the patient, and actually find them still in hospital. Target INR, duration of treatment, and last three INRs were not always provided in terms of warfarin, and GPs have indicated they would find that useful information. What was also a bit of a challenge as well is when there were discrepancies, it was actually known who to contact, because the name of the consultant on the discharge letter was not always the person who had seen the person during their care in hospital. As previously mentioned, patients have limited understandings of some of the drug changes. And in terms of some of the information as well, GPs indicated it would be helpful to highlight investigations that are outstanding, or new drugs which needed review, or the dose titrated. I mean, these last 2 points are not particularly issues as such, but in terms of how some of these issues are being taken forward, the last two bullet points on the slide here, and basically we do have a primary and secondary care interface group where these issues have been taken to and are being discussed and solutions sought. And you've also heard reference to HETMA, which is being rolled out, and hopefully that should improve the accuracy of medicines information when people are discharged. That's me. Thank you.
Thank you very much. Monica, do you have any final words before we hand the ball back to the team here?
No, I think that's been fairly comprehensive. Happy to take any particular queries.
Okay, and thank you very much. I guess the only other thing that we're really keen to share as part of the conclusion is that for each of the presenting boards, before we do get to the questions, we do ask them to share 3 key points that you've identified as something you'd be keen to be contacted to provide further information about. And we actually include those 3 key points in our rolling summary as part of our sharing information as these WebExes continue. So, and I guess the 3 key things I know you've identified, and thank you for forwarding them through, around the understanding the value of involving community pharmacy in the medicines reconciliation process. And I think it's fair to say too, the other point you've highlighted quite clearly is gaining the engagement and support of leads, whether they're medical, nursing or otherwise, is absolutely key. And I think that's a lot of people have found that a challenge, as you've noted, but it does sound like you've had some good success there. I'd be particularly keen to learn a little bit more about the levers that you've used to actually gain that engagement. We perhaps can talk about that in a minute. And also you've identified the experience of implementing HEPMA as another topic that you'd be happy to be contacted with. The other three things that you've shared as well is about things you'd like to learn from others. And again, I think it reflects some of your successes as well around gaining the engagement and support of the whole multidisciplinary team, and so to learn how other boards have gone about that. And how boards are sharing discharge information with their community pharmacy contractors. And for example, are people using Clinical Portal, giving community pharmacists access to that. And then the last one is about getting contemporaneous information from various specialist services out of hours and available to frontline staff. And I think you also mentioned the fact that the mental health team at the moment don't have access to ECS as a potential source, particularly out of hours either. So again, thank you very, very much. I think it's fair to say it's been a really, really comprehensive but very good overview of the work that's been going on in Forth Valley. There has been a lot of questions in the chat box, Monica. I don't know if you've had a chance to monitor them as we go through, but I would like to open it up first of all to Alistair to lead the questions with a verbal question, and then we'll go to the questions that have come through the chat box.
Yeah, hi, thanks, David. Yeah, I've put a few questions to the chat box because at my age I can't remember them all by the end. So I'll pick up a couple of them, but one, it's interesting to hear about HEPMA because we've heard from Ayrshire and Arden before, who've obviously had HEPMA for some while, about the potential impact on MedRec, and I know it's early days for Forth Valley. I just wondered if you could describe how the MedRec process on admission interfaces with HEPMA in terms of, does it reduce transcription from what would have happened previously with a paper cardex?
Catherine McLean here, acute physician. So we currently do MedRec on paper first of all and transfer it onto HEPMA exactly the same way that staff would have interfaced with a paper cardex. So the initial documentation is done in the assessment document, and then once that is complete, that information is transferred onto HEPMA exactly the same as it would have been onto a paper cardex.
So you've still got this sort of two transcriptions, if you like, one onto the taking the history initially onto the paper documentation, and then one, as you would have had, as you say, onto the cardex, but now into HEPMA. Would you be looking to change that at all in terms of being able just to do the reconciliation electronically, either within HEPMA or in some way that interfaces electronically with HEPMA? Maybe a step too far when you're just introducing HEPMA, I guess, at the moment, but I just wondered about thoughts on that.
We've not, so from a physician point of view, we've certainly not got any plans for that. And I think until we move to an entirely electronic patient record, we will have to maintain some paper records, and whilst we're doing paper records, I don't expect this to change dramatically from what we're doing. I'm not sure if Scott from Pharmacy has any other comments on that.
Yeah, I think the system at the moment doesn't have a MedRec module. It's something I believe is coming with an upgraded system that's coming from that supplier, and I don't know if the other system supplier has it available at the moment either, but there would be an electronic MedRec part or program that would sit in front of the HEPMA program, and then based on the plan would then pull those medicines across into the electronic prescribing document.
Okay, thank you. And can I just have a second question with regards to community pharmacy? So one of the things I was interested in is with medicines reconciliation processes embedded in GP practices, I wonder to what extent community pharmacies, when they receive the first prescription, are still detecting discrepancies that require to be resolved, whether that's been looked at all to see what the sort of percentage or the rate of errors is at that point.
The work that the GPs have been doing has been going on for quite a length of time, and they started well before community pharmacy started doing their work. So we haven't quantified the numbers specifically, but they weren't huge. But the ones that we found were significant because they'd already been through all the previous processes, and we were the last point before the patient would have received the medication. So whilst there weren't a huge quantity, they were significant.
And I wondered whether some of the ones are still being detected then, as you say, as that last kind of check there, is whether they've slipped through because the MedRec process either hasn't been carried out in the GP practice, or despite it being carried out in the practice, because you know, errors will always be there in a system. I don't know if you would have a feel for that or not, over and above what you've collected at the moment.
As well as the bundle data, we did interview each of the pharmacies involved in the process, and so we have some anecdotal evidence from them of specific cases where the information has been gathered. So I know that in some cases it was because it was too soon that the GPs hadn't got round to the medicines reconciliation, and in some cases it was more to do with patient understanding of what they were supposed to be taking. And there was one case I can think of where a GP deliberately changed what had been prescribed at the hospital because they had more information about the patient. So there was a discrepancy, but it was correct. The change had been made deliberately. But we were able to confirm that and explain to the patient why it had been changed again following discharge from hospital.
That's great, thank you. And actually I did have one more quick one. It was just, I put in a question about the template in EMIS, and I was just wondering if that's something that's available for all EMIS users around the country, or whether it's a specific development within Forth Valley.
As far as I'm aware, it's a zip file, so I would assume it can be linked to any system, but I can double check that with the GP involved.
Yeah, okay, thanks very much.
Thank you, Alistair. And we do have some time for some further questions, and there were a few that's been put through the chat box. And just to say that if we don't get to all of them, Monica will forward them to you, just so you can have a hard copy version of the questions that have been put to your presenting team today for a response. But hopefully we'll get through most of them. And again, thank you everybody on the WebEx today who has been asking questions as we've gone through. Frank's asked, particularly in the context of the, I think it was the mental health presentation. So Ross, the question was around how do you resolve issues that are identified during prescription review, particularly if they're identified by non-prescribers, so essentially that they're not in a position to actually make the change themselves. What kind of processes do you have in place to have that rectified?
Yeah, I saw that one on the chat, and I saw that we're not allowed green pen anymore, but I don't think anybody's told the mental health pharmacists that yet, so that we still have green pen to fix those things. And I suppose we don't have a process, we have a conversation round about it. Mm-hmm. So I think that the physicians here have a better process for it, a different process for it. Sorry, I should have phrased that more delicately. But generally, because we do all of our admission assessments in pairs, so there's always a nurse and a doctor, wherever possible at least, there's always a kind of team decision about what medicines are necessary. And there's not many psychiatric medicines that have to be given in an emergency other than sedation. And really, I suppose there's always time for us then to consider what's best the following day or when we've got a bit more information. So there aren't a huge number of time-critical medications that cause us a massive amount of trouble. But generally, we resolve it with a communication.
Thank you. And Frank, I hope that gives you some answers in terms of what you're looking for there. There was a question around how you actually assess completion within 24 hours, but I can see, Catherine, thanks very much. You've provided quite a detailed response in terms of in the chat box. So I might leave that for folks to have a look at, and because there are other questions that we don't actually have answers to at the moment. Alec from Fife was asking around whether the mental health and the acute teams actually have the same Cardex forms, and I'm assuming that's the question around hard copy, and I'm just not sure where that sits in the context of the introduction of HEPMA as well, but I think there are issues in Fife around the different versions of charts and the hard copy versions in mental health being able to be photocopied for the purpose of going out on pass. I'm just wondering if that's, have I asked a clear enough question? In the first instance, the question was around, do mental health and the acute adult teams have the same Cardex in use in Forth Valley?
The acute services all do. So acute admissions to mental health use the same Cardex as everyone else. But our rehab services, which are based on one of our community hospital sites, have, and only for the mental health wards, have the old Aberdeen-style Cardexes, which are still in use there. And now that we've moved, or are in the process of moving towards HEPMA, the plan for NHS Forth Valley is that we'll have a uniformed process across the patch.
Yeah, thank you. And so I didn't want to assume that that would be the case, but thank you for clarifying that way of moving forward. We still have a kind of question, maybe one more, and I'm going to take the prerogative of Chair asking a question particularly, but it's going back to the whole topic of, I guess, senior engagement or champions, and I'm really keen to learn a bit more about what levers, and I think it was Scott you mentioned in the acute setting, particularly with some of the consultant champions, what levers were available, or what were the key points that actually ended up engaging with those champions to get them involved and actually be the leads that make that impactful difference that a lot of other boards are finding quite challenging?
I'm speaking on behalf of my panelists, so Catherine speaks. I think Anne, who was going to come along and present today, but unfortunately was on holiday and left me to it. I think Anne had been on this case for several years and had been badgering and battering people to try and get engagement and moving forward. And then really once we then got the engagement of Catherine and starting to move that process forward, that's when we start to see significant difference that Catherine can allude to anymore.
I think data first and foremost, and what Anne came with was we're currently just gathering data, presenting those run charts, and putting it in front of us so many times that it was not possible to, and we blinkered to it anymore, and eventually it does reach the top of the to-do pile. The data was very much first and foremost an important thing. In terms of engagement from ourselves to our other colleagues, there's that balance of having unit-based data so that we can see how the whole unit is performing, and also being able to break that down into how individuals are performing and data relates to individual performance. Being able to give that on a personalised and individual and private feedback to people was also a very powerful tool that drives some change.
Thank you very much. So it sounds like persistence is one of the elements, and I think you're right, honestly reflecting too that the fact that the data is something that can tell a very powerful story as well. So thank you for those reflections. Just before we do close, I would like to thank again Monica and the entire team, Catherine, Carol, Leslie, Ross and Scott for presenting today, and thank you for everyone else who's joined in and asked questions. We've got representation, it's fair to say, from as far north as we can be in Scotland today and as far south, so that's fantastic, particularly when it's actually quite summery and warm in the holiday season, so we do appreciate your participation today.